is a huge honor today to be interviewing a fellow dentist, Bryan Laskin, turned IT communicator. How did you go from a dentist to a technological communication expert, communications guy?
Good question. I think it all sprang from my office. I built an office, merged with another practice about 4 years ago, and frankly just had frustrations with the interoffice communication systems that were available. And so complained to the right guy who was a friend of mine who had some developers on staff, and that kind of kick-started what's become OperaDDS. And it's since I've kind of been digging down this rabbit hole, it's been kind of going further and further, and kind of with what's come on with HIPAA and the importance of protecting patients' secure information online, it's kind of been ballooning from there. So it's transformed from basically a way for us to increase case acceptance and doing interoffice within the office to just spreading to all sorts of different communication.
Well, they say necessity is the mother of invention, and I love finding fellow dentists like you that had a problem, and that's what necessitated the invention. So what problems were you having, and how do you solve them with your developers, your software OperaDDS?
Well, the very first pain point I had was when I built the office. We had that light box system, the communicator in my last office, where half the lights weren't working. It was wood panel, and so you could put two lights on, and it would buzz you like Pavlov's dog. And I hated the thing, but it was necessary for me to know when I had to do an exam. And so the quote I got was $16,000 for my new office, and I was like, I'm not spending $16,000 on this thing that I hate. So we went down to the Chicago dental meeting, bought a few different systems, and I didn't like any of them. And so I was complaining to my friend and said, why don't we just make it so you can slap an iPad on the wall and then not just get buzzed, but get all the information discussed like a pilot's checklist before I walk in the room, so I know what's going on before I even walk in there. That way, the debriefing from the hygienist or from the assistant is for the patient's benefit, not for me. I already know what's going on. And so, and it's like lots of things, you get an idea like, oh, that sounds like a good idea, but then when you go and practice, those subtle variations are make the difference, between a little bit from good to great. It's from before we would pass sticky notes around the office and stuff, but when you go from doing it sort of the old-fashioned way to getting all the communication that you want instantaneously wherever you are in an organized fashion every time, it's a game changer. I mean, it really does. The case acceptance in our practice has just skyrocketed since we've kind of retooled all of our communication so that rather than having to have that in front of the patient or kind of going off to the side and having a private discussion, you're getting all that information wherever you are instantaneously. That was really the key for me that went, wow, this is, and then when I showed it off as sort of a demo to lots of dentists, and the ones that get it right away and go, oh my gosh, this is awesome. And so we've just kind of been building on it from there.
Well, okay, so let's get specific. So you just said something, we manage people, time, money. We make something, sell something, watch the numbers. You said it increased case acceptance. How does an interoffice communication device, an iPad in each room giving you information, how does that increase case acceptance?
Great question, and it's a long answer. But I would say,
take your time. You got an hour.
Well, thanks, sir. I think I just can't. I can't think that far ahead. I think the biggest thing is that in my philosophy, the most powerful words in treatment plan case acceptance are "I agree." I think that patients don't want to hear from dentists all the verbal vomit, the buckles and things that we talk about. They wanted it typically from an auxiliary member in language that they can understand. And when we come in and say, I agree, do you have any questions? In my experience, that's what patients really like. But to be able to do that, you have to have excellent communication with your staff so that they have to see what you're seeing so that you can, we use a process called calibration, which I know one of your buddies, Bill Rossi, here locally in Minnesota, taught me, which was basically you have your hygienist or assistant look in the patient's mouth, and you can calibrate on anything, but typically it's indirect restoration. So if you look in the patient's mouth, and if their mouth were your mouth, or their mouth were your mom's mouth, if you like your mom, and you would do an inlay, onlay, porcelain veneer or crown, that's one, and just count them up. And then we have, through OperaDDS, the auxiliary member sends that number to you. You go in, and if the hygienist says 2 and you're thinking 6, well, then you should have a discussion as to how things aren't the same. You do that for a couple of weeks, and you're seeing things the same way, or at least you understand how each other think, and that comes through to my watch, to an iPad that's stuck on the wall, and and then I can come in and say, well, Jane, you're a hygienist. It's best if you do a third-party endorsement. So you've got the greatest hygienist in the world. I completely agree. Do you have any questions? And that's, in my experience, that's what patients want. The more you talk, the more glazed they'll get. And I don't know if you agree with me, but that's really, to get that level of, to have it be that simple requires a sophisticated communication system. And so that's what we've tried to build out.
Now, the first thing these dentists are going to say when they're listening to you out there on their commute to work or their way home is they're going to say, yeah, but your hygienist can't diagnose. They always throw that up to me. And I agree with you. I mean, I don't think an X-ray or an intraoral photography, I don't think it's rocket science. I mean, you have a hole in the tooth. What do you need, an MRI, a CAT scan, a Ouija board? I mean, why can't the hygienist just say, yeah, you have a cavity? And I'm pretty sure Dr. Laskin is going to say that this is going to need a filling or a crown or an onlay, whatever, because you've calibrated. So what are your thoughts on that? That dentist is going to say, well, your hygienist can't talk. She should have duct tape on her mouth because she's not a real doctor. What would you say to that? Or he had not a real
doctor? Well, I'd say that's fine, but I like the way that you said it. I believe Dr. Laskin's going to say this because they're not really diagnosing. What they're doing is they're informing the patient on the front end what they think you're going to say. Of course, there's many times that I disagree, and I may be more conservative, or I may bring up something that the hygienist didn't see. But what the goal here is that hopefully you hire these people because they have a good brain and a couple good eyes, like you're saying. And if they don't get it, then either you have to redo your system so you don't do it this way, or else or you change people so that you have the right person that can get it. And so I think it's not that, patients that have, like you said, a big hole in their tooth, that shouldn't require me coming in and letting the hygienist know, boy, that patient has a hole in their tooth. If you don't feel comfortable with your hygienist sort of teeing it up for you, so you say, I agree, you can add more verbiage as much as you want to, but in my opinion, your case, for all the times that you're complicating it in the patient's eyes, case acceptance is going to drop. So it's not that the hygienist is always going to be right and they can't diagnose, but they certainly, you work with somebody and you go through a process of training, they should be able to say what you're going to say most of the time. If not, one of you, either your treatment planning is completely erratic and you're not mindful of why you do things, which is a whole nother issue. That's the other thing, is that calibration is as much for me as for the hygienist. When I go through a process of calibration, it's keeping me accountable for what I'm going to say. And if I'm busy in the next room, I still need to say, well, it's keeping me accountable for being consistent in my treatment planning so that we can be on the same page. 4 eyes are better than 2 in all cases, in my opinion.
And the calibration is also good for ethics and morals, because a lot of dentists will say, well, this crown needs to be redone because it has an open margin. And then the hygienist is saying, well, our last patient, you did a crown a year ago and it had an open margin too. How come, why isn't it calibrated? And I think it builds communication and trust and wow. And I believe the patient does want 3 opinions and doesn't always want the opinion from the doctor who they perceive as making more money than the hygienist. And,
I agree. Yeah. I just had this discussion with my hygienist that calibration isn't about you seeing things the way I see them. It's what would you want if the patient's mouth were your mouth? And so if you think I'm being super aggressive, I want to know that you think I'm being super aggressive. Or if you think I'm being, I just had a dentist, I did a lecture in Chicago last week, and a dentist came up to me and said, I think I'm way too conservative. I want my hygienist to help keep me accountable. great. This helps you with that. It like you said, it's great from just it's consistent care is quality care, both from procedurally, in my opinion, and also from a treatment planning standpoint. There's not every tooth isn't so unique that it has to be looked at, from a new set of eyes every time. We should have reasons kind of why we do things and a philosophy that we follow. And obviously, there's going to be the outlier cases, 1 or 2%, but the 95, 98% of the time, we should be able to agree without having a meeting about that specific tooth. In my experience.
And your hygienist has to wait for you sometimes. Sometimes you have to wait for the hygienist, whatever. But I always, when I had a new hygienist over the last 28 years, and she called this a watch on the MO, and I said, no, it's an MO. And as soon as I broke through the contact and was about to grab my number 4 round burr to take out oatmeal, I would buzz her, and I'd say, hey, come here, sit down. You wanted to watch this, and remember, what you see on the X-ray is only 40% of the lesion. So, every oral and maxillofacial board-certified radiologist says you're only seeing 40%. You called this a watch. You probably thought I was aggressive. I want you to sit down with a spoon excavator and take out oatmeal so you can see this, or whatever. So it's all about communication. So I'm going to ask the crude, rude, get to the point. How much is OperaDDS? What is it? It's an iPad for every operatory. Is it at 12 o'clock behind the patient? How much is it? How do you install it? How does the dentist get this? Do you have a demo video? If they went to OperaDDS, OPERADDS, and of course, if you're listening to this on iTunes, you don't get OperaDDS. If you're watching this on Dental Town or YouTube, this guy has more musical instruments, so I already know why it's OperaDDS. It looks like you're doing an opera right now. So where did you get the name OperaDDS? How does someone see a demonstration of it? Do they buy it through Patterson, Shine, Burkhart, Benco? Tell us, be more specific.
I will. Yeah, great. Lots of great questions. The name Opera actually comes from, initially it was the Interoffice communication system only, and it was Opera Pager. It was for the operatory paging system, kind of a play on words, because communication, opera, like you're calling down, like most people are yelling down the hall for communication, so we kind of did a play on words. And then when we built in HIPAA compliant email, laboratory, and specialty communication, I kind of dropped the paging because it's kind of old school. We still have the intra-office communication piece within OperaDDS. It's still called Pager, but it's free to use. So everybody can get on and just start using it for free. You asked about partners that I sell through. I'm a general dentist like you. I saw when I was starting to develop the intra-office communication system that some people were trying to do similar things to what I was doing, and what I really liked the idea of, I like small self-funded companies, and so I decided that's the way I wanted to go. And I thought that to do this the way that I would want to do it, if I send you an email or a case, I don't think you should have to pay to communicate with me. So I make it free for everybody to use. There are some, if you want additional users, so if you have a staff of more than 4 and you want to communicate with everybody, or if you want to have some advanced email features like viewing who opened your messages or retracting emails, then there's a pro account that's $49 a month. But we're going to be doing some more demo videos and that kind of thing. But really, if you go to OperaDDS, OperaDDS.com, like you said, you can register for free. There's no credit card needed. Just go on, create a username. You have to do a email verification just to prove that you're a human, and then you can get in and start playing with it. That's really the best way. You can start sending messages. We have an Apple Watch application, which is, for me, has been a big game changer. I thought it was going to be kind of a gimmick initially, but getting your intra-office notification on your wrist while you're practicing is just phenomenal. I mean, you know exactly right then what's being done in the room that you're being called to, and you can decide, should I go there or should I stay here? Just because with the flick of a wrist. It's pretty cool.
Wow, that is amazingly cool. My walnut brain never even saw that one coming down the pike. I never thought. I mean, I love my iPhone. I love the fact that I got an Apple TV, so if I'm watching like a YouTube video or a podcast or whatever, I can throw it up on my big screen. And my brother Paul, he's 17 years younger than me, so he's a little more high tech, and he got the Apple Watch and just loves it. I already have a smartwatch, a Garmin, which is the biggest brand name in Kansas, and I cannot wait till Apple includes all those features because it has 6 buttons, and you basically have to be an electrical engineer programmer to figure out how it works. And it seems like so many of my buddies who have had their Garmin for years are still asking you how to find this or that. So I'm sure Apple will make it classic Apple intuitive where an idiot can figure it out. So explain in detail what is showing up on your watch. So you're sitting there doing a root canal. Does your Apple Watch, is it Bing or Deep, or how do you know there's a message on your Apple Watch?
Well, good question. And I should mention, too, that you don't need to have an Apple device or an Android device. You can use any web browser. So you can just log in. So you don't need to download any software. You can use your computer operatories. I like Google Chrome, but you can use Safari or Explorer or Firefox, and you just basically you log into OperaDDS.com. There's a login, and you're ready to go. So you don't need to use a mobile device. A lot of dentists say to me, "I don't want my staff on their phones." Well, neither do I. I'm not, so my staff don't use phones. If you have like a float assistant, you can give them an iPod or a non-phone Android device to carry around. But to answer your question about the watch, what pops up is it gives you a vibration. So what's nice about that is there's no tone. The vibration is more subtle than, I don't know what your Garmin is. You could use your Garmin too, but you get a subtle vibration so the patient doesn't notice that anything happened, but you feel it. And then when you flip your wrist and you see that it's an Opera DDS message, and you can, in your settings, you can make a different type of vibration so that you know what they are, which I don't know about you with your smartphone, but I've had to like turn off some notifications because you get them all the time. And so you can make it so that whichever notifications you want to receive while you're practicing, you get. And then when you flip your wrist, whatever message that the staff member sends comes through, and you can see it right there. You can either just with one tap confirm it, or you can dismiss it, or you can do actually a text to voice reply, or there's some predefined messages. So if somebody says, are you going to be here in the next 10 minutes, you can just click yes with a tap of the button too.
So what percent, in your opinion, what percent of offices are using intra-office communication, and why are the ones using it, and why are the ones not using it, and what do those both camps need to know about the other camp?
I think that a very small percentage of dentists are using intra-office communication. I think it's, if I had to guess, boy, I'd say, 25%. And a lot, about a few years ago, the headsets were quite popular. They came on, like, if you went to a major dental meeting 5 years ago, there'd be all sorts of headset companies. Now you go and you're lucky to find one. And I think the reason why is because they're annoying. In Dental Town, you guys did a survey, and 80% of dentists that have that in their office don't wear it. And the reason why is because they're annoying. And if somebody says, "Hey, the buckle, could you check the buckle of 19?" You're not going to remember by the time you finish your root canal and go in the room. Also, one of my biggest pet peeves, the reason why I don't like the patient that notification be noticeable to the patient, is if your hygienist comes in and says, "I'm ready for an exam in room 2," the message you're sending to the patient that you're working on is that my focus is elsewhere now. You're not my sole focus. And so if you have a headset in, the patient's getting the message that you're always listening to other stuff in addition to listening to them, which I think is the wrong message. So I think that people use intra-office communication systems. My Lightbox communicator was better than nothing. The little buzz let me know that I need to be somewhere, but the patient could hear it. And like I said, it was like Pavlov's dog, which all notifications kind of are to a point. But what's nice about getting a checklist message in particular is that, I'm a linear thinker like a lot of dentists. And so if I walk in the room now and a hygienist starts talking about the perio before discussing the medical history, it throws my brain for a loop. I want everything in the same order every time. There's a reason why pilots do it that way. There's no reason why we shouldn't too. And so that's how every message comes through to me. It's in the same order every time.
Oh, I'm so glad you said that, because I used to always think that's a lot with me, that, the assistant will come in and say, start telling me all these words and stories, and I'm just like, stop. Which room for? Okay, new patient, existing patient, emergency patient. I just you can't start telling me about the symptoms until I need to know how much. Yeah, exactly. So what is your checklist, or what are the checklists on this system?
Well, it's all customizable. So I can tell you what mine is, but it might be different than yours. In my office, it's the patient's name, chief complaint, because I always want to start off with the chief complaint, changes in medical history, perio status, restorative status, what radiographs were taken, and then any restorative needs that were discussed, and then any additional information. And so that's what we get every time. What I get every time. Again, you can create whatever checklist you want. A calibration is in there. We take it on and off depending on if we're going through the process of calibration too, and that goes right beneath the chief complaint. So what's nice about that is then when I walk into the room, when we're doing the process of calibration, I know that, let's say Emily her number was 5, and as I'm looking in the patient's mouth, I can be kind of seeing, well, it's obvious which 5 are the teeth that could use indirect restorations, or let's say you're doing like you said, carious lesions, which teeth were carious, and if I don't see if it's not obvious, we can have that discussion. So that's the checklist that I have every time.
Now when Bryan Laskin is talking about calibration, it's Bill Rossi, and he has an online course on Dentaltown about how to do that, and so that's a must watch. When I got out of school, the big boogeyman was OSHA, and everybody was afraid of OSHA. And finally, one day, I actually decided. I was hearing all these mixed messages. This is back in '87, and a lot of it was brought on because of HIV was out, and everybody was panicking and freaking. And I finally called the OSHA, and I left message after message. This is before computers, internet, anything. I finally got the head OSHA guy in D.C. to call me back, and I just said, I'm hearing all these confusing things. Why am I buying a manual from different companies saying different things? What do you need to know? And he says, who is this? And I said, Howard Farran. He goes, what do you do? And I said, I'm a dentist. And he opened his chart and he says, 0.001 or less dental employees die each year here on the job. He goes, dude, it was something like, I forgot the numbers. It's something like 3 out of 1,000 agriculture workers die each year. No, I think it was 3 out of 1,000 miners, and 1 out of 1,000 construction workers, and 1 out of 1,000 miners, construction, farm workers. And it's funny because that week in the news, somebody lost both of their arms in a combine, a crane had fallen over and killed some employee. He goes, dude, if an OSHA inspector walks in a dental office, I want you to call me back and tell me why they're in a dental office and not in one of those copper mines in Arizona or a construction site or whatever. And then so that kind of fizzled away, and and it got rational. And now HIPAA's the new big monster, and everybody's living in fear. And so what is HIPAA? Explain to your viewers, what is HIPAA? How much of it is a fear reaction? But when the tires hit the pavement, what's real world HIPAA, and why did you add HIPAA to OperaDDS?
It's a great. I love the fact that you equated it to OSHA, because I do all the time too. I think that it's these big federal regulations that if you take a step back, there's a reason why we all wear gloves today beyond getting AIDS, right? There's a reason why we wear gloves and eyewear. Now you get to the specific details of the width of your side shields and stuff, and it'll drive you crazy. And I think that we're exactly where we are with HIPAA today that we were with OSHA in the 80s, where everybody's like, I'm not going to get AIDS from my dental patients. I've been practicing this way for 20 years. Well, in reality, there's cross-contamination to deal with. There's just general. It's nasty not to wear gloves, in my opinion, because I grew up after I graduated from dental school in '99, so I can't imagine practicing without wearing gloves. But I had dental school instructors who would ask the patients if it was okay because they felt like they didn't have the manual dexterity with it. And I think we're going through a similar transition, like you said, with HIPAA. Right now, there's a lot of people spreading fear that, you're going to get these fines and that kind of thing, which they're out there, but like you said, I mean, it's the risk is like getting AIDS from practicing without gloves. It's low. But however, the spirit of the law which is protecting patients' electronic information or just their privacy in general, makes a lot of sense. There's a lot of problems that go on when you send things through through traditional email. There's a lot of risks that happen. That's why banks are doing their PCI compliance. It's going through the same thing. Why people send stuff through a fax machine that's grandfathered into the laws, but it still doesn't make it the best way to do things. I think that protecting patients' private information is very important. And in dentistry, just like in medicine now, we're going through this weird growing pains where everybody wants all the software to work together and be interoperable at the same time, keeping everything secure. And those two kind of can be at odds with each other. And so I think most of the HIPAA compliant people talking about HIPAA compliance focus on the fines and the sort of the big problems that are very low risk but high, they're high impact if they happen. I personally feel that secure information is actually better communication. It allows for you to create tools that are more effective than doing them in traditional ways. So, for example, you can have your periodontist, your oral surgeon, your lab all working online using a single CT scan, discussing your fees so you can package them together. So when you talk to your patient, you're not giving them a range of fees that confuses them, and they just say, I'll just have a bridge versus an implant. You can coordinate your care because you have this online portal that's secure where you can all collaborate together.
And also, it seems like whenever your specialist is in between patients and gives you a call, you're not in between patients and not really wanting to give a call, but you really feel like you got to go take the call because the last time you called your oral surgeon said, "Can you see this guy right now?" And now you're not taking a phone call. So how does it smooth up that scenario?
Oh, for sure. I mean, it takes it away. I mean, why would your surgeon want to call you versus go online, open up the case, create a comment, and be done. And then you can see their comment right next to your comment, time, date, stamped. I mean, it makes total sense. There's all sorts of online collaborative portals. Pretty much every company in the world uses these systems. Lots of them don't have the secure piece. Like, Slack is a big online portal. There's Workboard. There's a lot of these for using email. Even traditional email is cumbersome for when you're talking about collaborating. So you want to have everything organized in one place. The fact that we as dentists tend to write out a paper slip that says the patient has a stinky draining abscess on number 3 and give it to the patient, and then they might leave it on their counter for everybody to see. And then we wait for something to come in the mail from the endodontist blows my mind. The patient wants to have that tooth restored right away, but that letter is coming in the mail in 3 days, but the patient's there, and so you have to call up the endodontist and go, boy, did you actually do the root canal? It just is for those of us that do it this way, it's kind of an archaic system, I think.
And the other huge advantage of a specialist is I want my if I send you an oral surgeon 4 wisdom teeth to be pulled, it really helps me if the oral surgeon says while the patient's numbing up. By the way, you had 3 cavities. I mean, you got that scheduled? Because I've been an oral surgeon for 20 years, and you don't want those 3 cavities to turn into 3 root canals. And then if you can't afford 3 root canals, then you're going to be back on my front door needing 3 extractions. Did you ever get those done? And then the dentist saying, oh, yeah. Because the patient might have been thinking, after I pull these 4 wisdom teeth, max out my insurance, I am done. And I don't want an endodontist to look at a toothache. I want them to, while that's numbing up or in the consultation, to see the whole treatment plan and say, yeah, okay, so this one does need a root canal, and then, of course, this one over here needs a filling, and over here you need a crown, and gum disease is the big deal. I hope you get those 4 quadrants of root plane and curettage, et cetera. So how does this eliminate phone calls for staff, though?
Well, you mean with other staff members within your office?
Yeah.
Well, multiple ways. You can replace email. So, email in a lot of ways can replace phone calls. So because you have secure email, you can not instantaneous communication can be handled that way. If you're working on an individual case, you can use an online portal that everybody logs into that case to view. Or if you're, for the most part, for the inter-office communication, it's kind of like a fancy text message. That's why there's a dedicated iOS application and a dedicated Android application, because then you can get the push notification. So if you're not even logged in, if you don't have the application up on your phone, it just pops up just like a text message that says Opera DDS and it has the message, or you can send it privately so people have to open it up to view it.
Tell them about your online CE course, Getting Staff and Patient Communication Right for Increased Profitability. How long is that? Would that be the ultimate staff meeting where the dentist goes and springs for some pizza or sub sandwiches and the whole team watches this together? Talk about that course.
Yeah, that course talks a little bit about kind of what we're talking about with the online tools, but it also talks about effective communication. I think that communication is really the key to an effective practice. So for things like, I go through things that like I call a testing phrase. One of my favorite threads on Dental Town is "Patients I want to punch in the face." I just think that's just the title of it makes, because it makes you a little bit of happiness, because we all have those patients, right? But when patients say, "I hate the dentist," what are they really saying? They're not saying they actually really do hate dentists, but they're saying that they don't feel in control, and they don't like that giving the control over to you most of the time. And so really, if you get beyond what the actual words that the patient is saying to the meaning. So if you tell the patient, who says that they hate the dentist, you're in control, just let me know whenever you need anything. I'm just going to present you the options, and you tell me what you want to do. You're going to just see the situation diffuse. Also, just subtle variations in communication. We all know that sit the patient up and look them in the eye, you would think, but I see it in my office all the time where just basic communication skills are dropped. We want to be on eye level with the patient, speaking to them. Just put yourself in the patient's shoes, and particularly for staff members, like you're saying, who might not have the experience with communicating with patients. There's all sorts of tools in that the Dental Town CE video that goes through, from what, in my experience, what creates good communication and high case acceptance in a practice.
What would you say to people who say, you're also very well known for CEREC. I mean, you're an amazing instructor. You have probably the best Patterson-certified training in your state. What if a dentist says, I don't know if I'm high tech enough for this? I mean, what other behaviors would this dentist do that would make you think, yeah, you're high tech enough? And then I want you to talk about how to answer that question.
Yeah, that's a great question, because I just spoke to a CEREC group last week, and they're two different buckets, but I think they're equally effective. Now, CEREC, one of the reasons why I love CEREC is it's same-day dentistry. You're finishing the restoration you started today. Patients love that. Talk to any dentist that does that. They love it, right? It's way more impactful than I thought when I bought CEREC 13 years ago. I was blown away with, you're there in the office every day. So if the patient has to come back, it's no big deal. But the effect on the patient, it's huge. I like to call, when you have effective communication in your practice, I like to call it no-visit dentistry. Because the patient comes in, they have a broken tooth. Rather than saying, okay, come back and we'll do it, in one visit, you're saying, I'm sorry, you walk in the room, hygienist hasn't left the room. The front desk has already looked at the financial arrangements. Your assistant already has the room ready. You walk in and you say, I'm sorry, Mrs. Jones, you broke out that tooth on the upper right. Abby's got a room ready for you. Let's get it taken care of now if you'd like. And patients, it blows their mind. You're going from getting the restoration done in one visit at another time with CEREC to doing it that same day. And you don't need to have a CEREC to do that, obviously. If it's a filling, you can do it today. If it's Invisalign, you can take records today. If you're doing a traditional crown, you can at least get the tooth temporized today. It doesn't really, if you don't have computers in your operatories, you can slap an iPad on the wall, but realistically, if you don't have computers in your operatories, you probably don't see the value of a cloud-based communication system. People who are using film X-rays, which blows my mind that half the dentists still use film X-rays, frankly, in the U.S. They're probably not going to see the value, but I think just like with digital X-rays, some pieces of technology just make things explode. And this one's easy. You don't have to buy anything. If you have a computer in your operatory, start using it for free, and you can, unless I pay you to use it, you can't get any better than that. Yeah.
So I want to be a good interviewer, throws the hard questions, no softball stuff. So I want to go after the biggest complaint of CEREC, that this dentist used to take an impression, send it to the lab, and go off to the next patient. And now he's sitting in the room being a lab man. He paid $150,000 to demote himself from a doctor to a lab tech. I kind of think that they work best, like how I use it, delegating with my staff. I want you to, just like you said earlier, that hygienists legally can't diagnose, but we get around that by saying, well, in my opinion, listen to talk show hosts. The reason they never get sued, if I said Bryan Laskin is a heroin addict, and I was joking, well, that's not joking. And if he sued me, I'd have to prove that you do heroin. And if I couldn't prove it, you could sue me for slander or what have you. But they always say, well, in my opinion, Bryan Laskin's this, or in my opinion, or I think, or I heard. They always do these disqualifiers, which your hygienist can do. But I want you to go specific to the claim that this dentist bought a CEREC machine, and now they're doing the whole process, and it's taken them, 3 hours in the room. So they used to have an hour. You would come in, Brian's got a broken tooth. I'd numb you up. I'd take an impression for a temporary. I'd prep it. I'd take an impression. I'd make temporary. You're out an hour. You come back in 2 weeks for 30 minutes. Now I'm in this room for 3 hours making a CEREC crown, and the dental consultants are saying, my God, he spent $150,000 to demote him to a lab tech. So I want you to address that. What can you delegate out on your CEREC? Because you used to use a lab man. I mean, you used to have a man sitting on a bench in another building making this whole crown. So why can't your assistant make it in your office? And what is the maximum length of time that the dentist is doing this CEREC in a crown before it's no longer profitable? And by the way, some of these patients are not happy if they're sitting in there in a chair for 3 hours. So can you address that?
Yeah, we're very efficient in my office. So the longest a single unit is going to take is an hour and a half. If I'm doing it, some of my associates might take a couple hours if they're doing a difficult Emax crown, but it can be very efficient. And it blows my mind. We're as by the book as you can be. My assistants, I'd let them drill my own mouths. When I've done training, they've prepped the models. They're fantastic. But I still check the restorations before we hit mill, and they won't remove the sprue from the restoration because they called the Minnesota Board of Dentistry to see if they could do that, and they said that's altering a final restoration. So no, can you do that? I don't know. Like you said, you probably have a 16-year-old that just got off heroin that's making a restoration at the lab. But my assistants that I'd let practice in my own mouth don't feel comfortable removing a sprue because it's not legal. So it comes down to how the dentist wants to practice. Now, a lot of dentists, right now still, it blows my mind that only 10% of dentists have CAD/CAM dentistry, because I've been doing it for 13 years and I just see the success in my practice. People haven't had the same success. So some people don't want to design and mill. That's fine. You're still going to get a much better restoration using a CAD/CAM system and then temporizing and getting the patient back in a couple days and putting a permanent restoration on it. There's a reason why all the labs are going to CAD/CAM now. It's because it's more predictable, just like the checklist messaging. And predictability is quality. So you don't have to do it in the same day. I think you're going to have much higher patient satisfaction if you can be efficient about it. If I do a CEREC crown, my average one that's like an Empress crown will take about 40 minutes. And early on, patients would say, I paid you $1,500 for 40 minutes. You're right. You should have probably paid me $3,000 because it only took 40 minutes. Patients aren't looking to pay by the minute in dentistry. They don't want to be there longer. Maybe a little bit on the hygiene side, in my opinion, but not operative.
You're an elite trainer. What is the person? Because some of these CEREC machines are sitting in the closet because they couldn't get their times down under 3 hours. What is? If you're a dentist listening to this now, or an assistant or a hygienist, and your doc's in there for 3 hours, and you just said you can do a single in 40 minutes, and that you'd like them pretty much all done in under an hour and a half, how do we close the gap? How does the consultant world close the gap between the whole staff screaming, he's in there 3 hours with that thing? How does he get from 3 hours to an hour and a half, let alone 40 minutes? Is that just a time thing? Is that just something, or what would you say?
Well, I have a Dental Town CE video on the efficient all ceramic preparation that kind of goes over a lot of it. But it really boils down to about being mindful of every step you do. It has nothing to do with rushing. It has nothing to do with moving fast. It has to do with, for example, using 2 high-speed burrs. When I do an all ceramic crown, I use 2 high-speed burrs, and oftentimes I'll have 2 high-speed handpieces there, so I don't have to change burrs. So each burr has multiple purposes, what
are those 2 burrs?
It's an egg burr that's 2 millimeters in diameter, so it acts as the gross reduction for the occlusal surface, and also a depth gauge because it's 2 millimeters in diameter so then you just sink that in the central fissure and go across.
Egg burr, egg, like an egg?
Yep, exactly.
Eating an egg, perfect.
Yep, and I use 2 new burrs every time. Then the second burr, it's usually like for a molar, it's going to be a 1.6 in diameter modified shoulder burr with 6 degrees of flare. So I bring down the occlusal table in the central fissure down 2 millimeters, then I take off the buccal and lingual, staying occlusal to where I want my margin to be. That's when I'm going to switch burrs, go around the shoulder preparation with 6 degrees of taper is built into your modified shoulder burr. So you just kind of go around it. It's pretty simple. Drop things apically as you need to. And then I lay it flat. I create the pulpal floor to be nice and flat because you don't want any discrepancies for CAD/CAM. Then just round the corners and you're pretty much done. If you have to do, restoration removal or caries removal, that's when you grab your round burr and then go back with your modified shoulder to refine the preparation. So some dentists are taking 40 minutes to prep a tooth. If you gave me 40 minutes to prep a tooth and I went as slow as I would probably have to use the round burr to do the whole thing.
Now, do you also use an end cutting burr, just a cylinder with the end cutting for the floor of the prep?
Well, I use the one burr, and so it end cuts.
Does it have
side cuts?
Oh,
yeah.
it has an end cut too.
Well, yeah, the whole burr, the whole thing cuts. It's diamond, so it's all diamond coated. Yeah. And I use 1.6 millimeters in diameter because then you can have the burr hanging off the margin, so then you get a flat margin. So you don't have to go back with an end cutting burr. If when you I've been doing it for 13 years now, so if you need to go back with an end cutting burr to kind of refine your margins, that's fine. But I think you can cut a rough prep with a smooth burr, and you can cut a relatively smooth, depending on the roughness of the burr, you can get a nice smooth.
You know what I actually love the most about CEREC? What I love the most, it was the when you come out of school, you use your naked eyesight, and you had to listen to older dentists for years before you got smart enough to get magnification, and then that opened up a whole new world. But I remember, getting these preps and look at them on your computer screen. It's probably got to be 40x, and it's just like wow. I mean, you just don't know what a good prep is until you've seen how horrible your prep looks at 40x, and it's just a whole new world.
Yeah, we made the switch from, I don't know if you were using it with the red cam days, but then it went from normal definition to high definition, and suddenly my prep sucked again. So I had to have a whole. So
you got out in '99. I bought my first CEREC 1 in 1990.
Oh wow, that's awesome.
So I've followed, and I got to talk to the guy who actually invented it in France.
Oh yeah.
And we're going to do a podcast, but he doesn't feel comfortable doing it in English because he speaks French.
Oh yeah.
And so I've either got to learn French or we got to find an interpreter. But I just want to get him on there because this was his baby. I mean, it was his baby forever, and I just think that's so cool. But yeah, do you think it's anal also? Do you finish that prep with Softlex disc or anything like that, or do you think that's too? I mean, I do that. I always want to do the adjacent teeth, the prep. Do you think that's just silly, or do you think that? But you don't see a need for that, or?
Well, I don't think it's silly, and I think that it depends. Obviously, if you nick the adjacent tooth, you have to polish it. I think. I've gotten used to using diamonds for my preparations, just because that's what I'm comfortable using for the most part. I don't use Softlex discs we use the product that we use is a Super Snap. Again, I like things that are predictable and efficient. So we have the one pack where the mandrel's built into it with all the discs, and it's disposable. Because then you're not searching for mandrels or any of that stuff. It comes down to everybody has things that they like to do and ways that they do them. It just comes down to we're very obsessive about having a purpose for everything we do, and I go through the same process pretty much every time. So I know I don't even think when I practice anymore because my assistant is just passing me what we're doing. Because there's nothing, there's teeth, typically speaking, particularly when you're talking about CAD/CAM dentistry, where you want a more simple preparation because you want to be able to mill it out with a burr that's usually 1.2 millimeters in diameter. So you don't want these subtle variations. You want things to be smooth and rounded and flowing. And so it's not really, there's not a lot of thought that has to go into the preparation most of the time. And even if you're doing a 15th, 16th crown, you should have the restoration in mind before you go ahead and do it. Just like an athlete who, who's let's say a pole vaulter, they're going to visualize what they're doing before they do it. You want to go in with a plan, just execute the plan, and you're going to get better results all the way around.
That's true. I don't do that with pole vaulting, but when I walk into a Mexican restaurant, I already know what I'm going to order before I walk through that door. That's my version of pole vaulting. So Bryan, 10% of American dentists probably have a CAD/CAM machine. 90% don't. You alluded earlier that only half are up to digital X-rays, half won't. What would you say to the 9 out of 10 dentists listening to this that do not have CAD/CAM? Because let's be careful. This is what they're telling me. They're saying, dude, I just walked out of school with $250,000 of student loans. Now Bryan Laskin is saying drop $150 on a CEREC, and then some other guy saying drop $100,000 on a CBCT, and then they want me to buy a laser for $75,000. Should a dentist? Address that fear. They're saying, Larry, Bryan, if I listen to you, I double my student loan debt, and then I'm trying to be the voice of reason, saying, yeah, but your student loan debt and all those things combined will only be half the cost of your divorce. So just knock yourself out. So what would you say to that guy? Should you come out of school $250,000 in student loans and drop another $1.50 on a CAD/CAM?
Well, that's a good question. When I signed the paperwork on my first CEREC, I had just bought my second practice in 3 years, and when I signed the paperwork, I almost cried. My CEREC rep, we laugh about it to this day. I was, because I knew it in my head that this was probably a good financial decision. But when I was signing that paperwork, I was going to cry. Now I have 2 full systems that I just dump money. It's easy for me to say because I've bet every piece of technology I've focused, I protect my downside. I look at the upside, and it's been good. There's been some things that I've done, obviously, as we all have, that, we just talked with my clinic administrator today about an ad that we did that just totally stank. Well, we're not doing it anymore, but we were protecting the downside. I would say that for the most part, people who start using technology see it, embrace it, and start using it. So start off with the easy things like digital X-rays. In my mind, there's no reason to not use digital X-rays. An Interoffice communication system that's cloud-based, that's free, I mean, my God, start there. Once you start doing that, you go, oh, this is great. Then if you want to take the baby steps, you could do CAD/CAM dentistry that you don't mill and design like we were talking about before. Get an intraoral scanner. I think that I'm a big proponent of getting that dentistry done that day. I think getting it done in a single visit, there's just so many pluses to that. It's hard to ignore, but you want to start off with, what are the priorities? If you just got out of dental school, my opinion, you go, well, learning a new CAD/CAM system and designing it and milling it, maybe that's not the place to start. But getting your case acceptance sure is. You want to know that you want to track your case acceptance. You want to do the things that are required to increase case acceptance and get people coming in, and then work on the other pieces of technology. I wrote an article that's coming up in the new grad edition of Dental Town too on it's basically from the perspective of a new dentist who joins a practice that doesn't have any technology, and the safe places to start. You want to use things like, things that are free, so that you can see the benefit, or things that you're going to be able to shift the cost. Digital X-rays are far less expensive than film and all the stuff that you need to use a hazmat suit to change the tanks and whatever. So why not shift? Same, if you look at, and then if your lab bill is $10,000 a month in doing crowns, then it's an easy shift. My CEREC, my lab bill went from $7,000 the first month to the month before I got CEREC to $2,000 next month, and I haven't looked at it since. My first CEREC took me 4.5 hours. It was a BOL inlay on a friend of mine, and I had no idea what the hell I was doing, but it's still there. That restoration today would probably take me half an hour. So I mean,
why did you do it on your friend instead of your mother-in-law? What are friends for, huh?
I like my friends.
You like your friends. I want to go back to you just said you did a marketing piece that didn't work and no return there. But you also said something genius that you bought another practice. Why do you think it is in the Fortune 500 company? Well, take a Fortune 500 company that we all know, Henry Schein. They have, over the years, under Stan Bergman, have merged and acquired 36 companies. And a dentist will be figuring out that it's costing them about $250 or $300 to acquire a new patient. And then here's old man McGregor across the street retiring. He's got 1,000 charts. His practice for sale for $100 a chart, and they don't even think about it. They don't even look at it. So why do you spend your time in two different practices, or did you do a merger and acquisition, bought the charts and moved it into your practice? Or talk about your merger and acquisition, which I think is the most overlooked marketing piece, business event in all of dentistry.
Yeah, I just bought one last week. So I've bought 4 practices over the course of 2001, so 14 years, and I've merged them all in one location. Now it's getting a little hard because we just put in 3 more operatories in March, and we're already bursting at the seams. So I agree with you. Those of us that have done it, it's not always this easy, seamless transition. There's staff mergers and fee schedules and things, but the pluses far outweigh the negatives in the majority of cases. And for every practice I've purchased, I've probably looked at 5. So you're in Wayzata, Minnesota. Is that how you say that? Wayzata. Wayzata. Is that a suburb of? It's a suburb of Minneapolis. They were 5-10 minutes west of Minneapolis.
Okay, so would you tell yourself it's an urban practice, or are you driving out of Minneapolis and going through country before you get to your town? I mean, is it a small?
It's a first ring suburb.
Okay, so how far away can these practices be? And what percent of the patients roll into your office? Well, if you bought 100 charts, how far? You said you bought 4 or 5? 4. Okay, how far were these 4 practices distances, and did that affect them rolling into your office? I mean,
every time.
And I'm smelling your 3rd online CE course. I really think you really need to do an online CE course on mergers and acquisitions. I mean, I just thumped my head. I mean, especially in rural America. I mean, I just cannot believe how this is so overlooked. I mean, you should always be scouring the practice for sale in your neighborhood. I mean, and sometimes you'll tell a dentist they didn't even know the practice for sale. You know, the classified ads on Dental Town are free. You can list a practice for free. You can look at, I mean, it's a very busy section on Dental Town of business-minded people looking at mergers and acquisitions. So talk about that. You got 4 practices. How far away were they? How many of the patients? And do you have a dollar amount on that practice that you compared to what it would cost you to go out and get them through other forms of marketing?
Well, I've done it several ways. And I think each practice comes with its own opportunities and challenges. But, again, you just have to protect your downside and look at the upside. To answer your question about do patients come from those practices, it blows my mind. Every time I think there's going to be some attrition. And in reality, these patients are going to have to go somewhere. They're going to either go to somebody else, which is totally new, or they're going to come to see you and give you a shot. And everybody comes and gives you a shot. And as long as you have the type of service that blows people away, they're never going to leave. We have people come in from Europe they come back, and when they're in town, they still see us. And they weren't even patients of mine. They were, the dentist retired 6 months ago. I think dentists grossly overestimate the amount of attrition that will happen when you purchase a practice. The people drive by 150 dentists to come see me all the time, and I just, they maybe met me once in the hallway. So it's really about the patients. Patients are willing to drive. And if you're in a rural area, it's probably 1,000 times more likely that they'll drive to you. But people drive way out of rural areas into me and across the city to come see me, even though they haven't seen me as a dentist. And now I'm going through the process where I've hired. I have 4 full-time associates. The senior one is 3 years. Then one that's been with me for 1 year, one 6 months, and one for about 2 months. And I see the same transition. As long as they give them good service, patients are, for the most part, willing to see another dentist. You just have to give pain-free anesthesia and treat them well, and have the staff treating them well. I don't think that people are going to go somewhere else. And I agree with you. The where I am, it's not a growing community. So the cost for me to market and acquire new dentists, which we do a lot of, or new patient, is high. So if I can buy another practice, it's a fraction.
And how far away were these practices?
Well,
because I know a practice for sale from this guy who shot a lion, and I was thinking that maybe I should buy that, but it's 1,000 miles away. But how far were these practices? And
I'd say several miles. And the biggest one I did where I purchased a practice, I never practiced with the guy, but I've known him since dental school, and I liked him and wanted to work with him for a few years before he retired, and neither one of our facilities was big enough. So he was about 10 minutes. He was about 10 minutes away from a building, and I was about 5 minutes away from a building. So I purchased his practice, never practiced with him. 6 months later, we both moved into the building the same day. So his patients didn't just have me buy his practice, but they were totally transposed to a new building his practice had looked the same for 40 years. So, and that transition was very seamless. You need to keep some staff in place, communicate the message to the patients. We give them an offer to come in to see us that first time, and then you give them a tour, you blow them away, and then, you talk about everything that's the benefit to the patient, the expanded hours, expanded availability. We now have CAD/CAM dentistry, so we can do your crowns that same day. All those things, patients are very willing. As long as there's lots of benefits for them, they're not going to go somewhere else.
And what are your hours and availability?
We're open Monday through Thursday, 7 to 6, Friday, 7 to 4, and then we have some Saturday appointments too.
Yeah, so you have early morning, evening, and some Fridays and Saturdays, and I would say probably 85% of all dentists are Monday through Thursday, 8 to 4.
You probably know that better than I, but I know that.
And just to make sure that you know they're not friendly, they even close down for lunch the same hour of your lunch hour. They're like, we just we're just going to go ahead and follow that left jab with a knockout right punch. So do you have a dollar amount when you go to a merger and acquisition and you're looking at an office? What is your definition of an active chart? Is it someone who's been in the last 12 months, or do you go 18 or 24? And are you doing the valuation on that chart, or are you also valuing up dental equipment and goodwill and all that kind of stuff? I mean, is it just it costs me $300 to market to get a new head in my office, and I can buy this practice for $200, thus no decision buy? How do you wrap your brain around that business deal?
Yeah, it's different today than it was previously. At one point I bought a practice for the physical location, which I would never do that today, because the physical space, I think, is cheap now. Back then it was like, it's just like we were talking about CEREC or incorporating a communication system or something. Once you go through it, you kind of, you gain the knowledge, and now it has nothing to do with equipment or space. You can always build space. You can always buy equipment. For me, it's all about the patient base that's there. And there are some specifics, if that dentist is going to stay on or not, and if I want them to or not. So there's different ways to structure the deal. And whenever I look at a practice, I kind of weigh all the options, and then I would structure. I look at it, so I structure it in a way that it works for me, given all the variables that are there. And if it works for the other person, great. If it doesn't, then I'll move on to the next practice.
And how many years will you finance this practice over?
Well, it depends on the practice. If it's big enough, I don't have a problem financing a practice myself. Well, I shouldn't say that. I don't know because at points in time it's been difficult for some dentists to get financing from banks, but I've never had a problem with that because we've shown a history of being aggressive with paying off funds and things like that. And as long as you can make a good business case, I mean, as you're alluding to, for the most part, dental practices are inexpensive to buy. So all you have to do is show the bank a way that they're going to get their money back, and they're probably going to loan you money at a very low rate because dentists are just about the least default rate that there's out there. Yeah.
Oh yeah, it's less than half of 1%. I mean that's why they love us, and that's why so much venture capital money flowed into corporate dentistry, because they just saw that. So we're completely out of time. We're 2 minutes over time. Are you going to CEREC 30 in Las Vegas?
I am. We'll have a booth. Yeah, for sure. Come by.
What are the dates on that, and tell them about your booth?
It's September 17th that's the Thursday through that Sunday. Yeah, it's going to be great. I mean, that's just going to be a fantastic event. I don't remember the booth number, but it's Opera DDS. And so if you stop by, we're giving away an Apple Watch, and everybody that signs up for a pro account, we have our little Wolfgang, the monkey mascot, that he's a slingshot monkey. You can come by and pick one up.
Well, I just got to end with man. I mean, you've been at Townie since 2003. You're coming up on 1,000 posts. I mean, you're a legend in so many people's minds. Thank you for your online CE courses. Thank you for you're the busiest guy I know, and you just spent an hour with me. And so my last question, I got to go. Please explain all those musical instruments. And I'm totally loving Darth Vader's head over there, everyone's idol. So what's all the musical instruments? What do you play?
I play guitar and bass, but I just love to play. For me, it's a hobby. If I got too into it, I probably wouldn't enjoy it as much. So I just like banging away. And thank you for Dental Town. It's just such a great community, newspaper or magazine and online forum. It's just a force in the industry. So and you yourself are just a dynamic lecturer that I've seen many times, and I appreciate everything you do for the profession.
I want to see you lecture with the Darth Vader hat on. Why are you counting down to Star Wars numbers? What is it? Their 7th movie?
If I tell you the details of the nerdom of Star Wars, that the layers in my family, I would be very embarrassed. Yes, we're very into it. Yeah, and right now there's a bid going on so that you can buy 6 tickets to go see the new movie. at the Lucasfilms in California, and so I'm trying to rustle some friends together to see if we can win the bid.
Wow, I have to tell you, Star Wars is I can't even get my mind around it because I've got 1,000 books over here. If I panned over to my my library there, I've got 1,000 books. I just cannot read a fiction book. I always think if you're reading something, you're not learning, you're wasting time. I got too much to learn for I don't get fiction at all. But I love Star Wars. Total. I mean, my 6 favorite movies of all time are the 6 Star Wars movies, and I just said to myself, how does a guy that doesn't do fiction, why does he love Star Wars so much? So I just think that's everyone's movie. That is just the best. But hey, thank you so much for your time, and good luck with Opera DDS. Let me know if there's anything else I can do to help spread the word in there because I love getting dentists great information. They can do dentistry faster, easier, better, higher quality, lower price, and that's everything that you're about. And I do hope you do a course on mergers and acquisition. It is the most overlooked thing. Corporate dentistry is growing so well because these guys go raise a bunch of money from Wall Street and offer retiring dentists liquidity. And why aren't the other dentists offering this dentist liquidity? And then 5,000 graduates roll out of school, and these dental offices they're sitting there 168 hours in a week, and they don't hire any associates. So then corporate dentistry hires them. So corporate dentistry is giving liquidity to a selling dentist and hiring your associate. And you're the master. You've acquired 4 other practices and you've provided 4 jobs. If 5% of the dentists were like you, there wouldn't even be corporate dentistry. So I tip my hat.
I'd love to.
Everybody needs to know more about how you're thinking. I hope you do a mergers and acquisition online course. But thank you for your time.
Thank you for your time. Appreciate it.
Now I got to leave. I got a date with Princess Leia right now.
Okay. Have fun.
All right. Bye-bye.
Bye-bye.